Okay, guys, good afternoon. Thank you for joining us on this Friday afternoon for the HPB session. We're super excited. We have a little bit of a format change today. My name is John Lyons. I'm a surgical oncologist. I work in Baton Rouge, and they've asked me to talk on hepatocellular cancer today, so I'm going to get to that in a second. We have two additional speakers, and we had a third speaker who's unfortunately not able to be here. So Randy Cannell is going to be our panel discussant today, so we're going to change it up a little bit, but we hope it's still interesting and useful for everybody. I'm a surgical oncologist. I do general surgical oncology, but in the world of surg-onc, I focus on liver, pancreas, skin, and soft tissue. So I've been asked to speak today about hepatocellular cancer, screening and the road to early detection. As everybody in this room knows, cancer screening saves lives. These are the data from cervical cancer. Over the past 40 years, as the pap smear has become more prevalent, the cervical cancer incident rate has fallen, as has the cervical cancer death rate. Colon cancer similarly. The red line illustrates the screening rate, and as the screening rate has gone up over the past 25 years, the mortality rate from colon cancer has diminished. Similarly, breast cancer and prostate cancer over the last 30 years or so, as we have improved and increased our screening modalities for breast and prostate cancer, the mortality rates for these two malignancies have similarly fallen. The way we assess the success of a screening tool is called the mortality rate ratio. And it sounds really complicated, but it's actually pretty simple. A randomized trial is conducted, and they look at the mortality in the screening arm compared to the mortality in the control arm. And so that ratio is what's assessed. It should be less than 1. And this is the rate ratios of the various cancers for which we have screening. And so an adequate number would be somewhere between 0.7 and 0.8, something like that. So where is liver cancer? Where is liver cancer on this? Well, there is data to support screening for liver cancer, and we have a randomized trial that was conducted looking at screening in liver cancer. There's only one to date, so it's an important trial because of that, but this is what most of our data is based on. 18,000 patients diagnosed in Shanghai with chronic hepatitis B. They were randomized to have, 9,000 of them were randomized to have either ultrasound AFP, which is our standard screening modalities, versus no screening at all. The primary outcome was standardized mortality from HCC. This is the data. So in this line up here, this is incidence on the y-axis. On this line here is screening, so no surprise that at every time point you have a higher incidence of, you're picking up more cancers because you're screening them, so the incidence is higher in the screening arm. But this is where it gets interesting. So screening is over here, control is over here. And in the screening group, you have about 60% of patients diagnosed with early stage disease, stage 1 disease, 0% of patients in the control group. Clearly, it's effective. And similarly, if you look here, the treatment, liver-directed treatment, about 80% of patients versus about 50% of patients in the control group. And where the rubber meets the road down here is the 5-year survival. So you have about a 46% 5-year survival in the screening group from HCC related to 0% in the control group. And if we get back to that number I was quoting a minute ago, the rate ratio, the rate ratio is illustrated here, and it's 0.63. So if I bring you back to the initial slide showing the effectiveness of cancer screening with all of these rate ratios, liver cancer is right in there. So clearly we have data to suggest that liver cancer screening is valuable and should be done. But the problem with it is this is a single randomized trial. It's old. It was done 20 years ago. It was in a Chinese population, and the patients didn't have cirrhosis. They had chronic hepatitis B. So the argument is this really generalizable to a Western population? So I have some additional data for you. Multiple single-arm prospective studies have been conducted looking at screening throughout the world, in the West and in the East. This is a meta-analysis looking at over 30 studies looking at the relationship between screening and HCC outcomes. So This is a meta-analysis, so the forest plot here, but I'll point your attention down here to the bottom. So the pooled odds ratio for early detection in the screening arm was twofold higher, so suggesting that patients who were screened have a twofold likelihood of being detected at an earlier rate than those who just were observed. Similarly, this is the curative treatment rate, again, about a twofold increase in the curative treatment rate amongst patients who were screened. And when we talk about survival, about a 1.9-fold increase in 3-year survival amongst patients who were screened. So again, this is the data that we have supporting screening for liver cancer. But why do we care about liver cancer? I mean, what's the big deal, right? It's not as prevalent as lung cancer or prevalent as breast cancer. Well, I think we should care about it for a few reasons. HCC remains the fastest growing cause of cancer death in the United States. Most patients, as I showed you in that randomized trial, do present at late stages, and when they present at late stages, as we all know, our options for treatment and our cure rates are extremely limited. If you live in Louisiana, and I suspect a lot of you guys do, it really hits closer to home because this is the mortality data for the country, okay? And red is bad. Louisiana's red, and that's bad. And this isn't a political statement. This is just a color associated with mortality. And if you look at the table here, we're second, at least at this time, and we're still top 10 in liver cancer mortality. So it's a major problem. It remains a major public health problem, and it's not going away. When you look at screening, you always have to ask the question, is it cost effective, okay? And because obviously we've shown that it's effective, but is it cost effective? The way we do that is we assess the quality adjusted life years, and that's what this graph shows, okay? So what these researchers did is they looked at no surveillance versus ultrasound with AFP, and they assessed the cost per quality adjusted life year based on the incidence of HCC. And they found that the curves separated and that the screening with AFP and ultrasound became cost effective when the incidence of HCC was 0.4%. So what does that mean? That means for average individuals, it's probably not cost effective. That's why we don't screen the entire population. But when your incidence is 0.4% or greater, then it makes sense to do it. Patients with cirrhosis typically have a incidence of HCC development of about 1 to 2%. That's an early stage. It obviously depends on the severity of the cirrhosis and the etiology of cirrhosis, but at a minimum, when you read about the incidence of HCC with cirrhosis, it's at least 1 to 2%. So my point is, living here, you definitely have a cost-effective screening. So I think this demonstrates not only effectiveness, but also cost-effectiveness. Currently, these are all the organizations that recommend screening guidelines, that have some sort of screening guidelines for liver cancer. And all the American GI associations, all of the major American cancer associations all have screening guidelines, with the exception of USPSTF. And we'll talk about that in a minute. But the Asian societies, the European societies, all recommend screening for liver cancer. And these are the people who NCCN says we should screen: cirrhosis from any etiology and chronic hepatitis B. Most of you all know this, but just as a reminder, liver cancer screening is recommended to be done with an ultrasound and an AFP. Okay, the AFP is a little bit debatable, but the sensitivity is higher when you add the two tests versus doing one alone, and it's recommended to be done every 6 months. But the screening rates are low. It's not like breast cancer or colon cancer where it gets a lot of attention. This was a study that was at UT Southwestern about 15 years ago, looking at national data and assessing the rate of screening. They found that consistent screening was only in about 18%, and that number really hasn't changed. If you read about it in 2025, it's still about 20, 25%. It's not very high, and it's even lower in areas like Louisiana. So there are barriers, right? Why is that? Well, there are barriers to the test, okay? So you've got ultrasound, you've got problems with ultrasound and AFP, okay? So in the case of ultrasound, it is a low sensitivity test for early stage HCC. It's hard to see small lesions, especially when the morphology of the liver is cirrhotic. It's operator dependent. It can be less reliable in obesity, and that's significant because obesity is becoming the major etiology of HCC. It's overcoming viral hepatitis. And then AFP is also limited, right? So you can see the sensitivity, the specificity is quite good, but the sensitivity decreases as the AFP, as the threshold increases. There are also patient and provider-related barriers, and you guys are aware of all of these, right? So patients may have lack of awareness. They may not know that they're cirrhotic. They may not be aware of the relationship between cirrhosis and HCC. There's the lack of transportation. There's the lack of knowledge. There's healthcare literacy. Provider-related issues have to do with decision fatigue. The data demonstrates that you're more likely to receive a screening test if you see the doctor earlier in the day, or you see the provider earlier in the day, or if you have fewer problem list diagnoses. If you have a smaller list of problems on your list and less decisions the provider has to make, you're more likely to get a screening test ordered. That's the data. Many people forget to order the test as a result of this. And then obviously there's the underdiagnosis of cirrhosis. And then there's no USPSTF recs. So those are all challenges. We usually use that as the industry standard to guide screening guidelines. And we don't have that in liver cancer. So that's a major challenge barrier to why liver cancer screening, at least I think why liver cancer screening is not done enough. There are success stories, okay? So in the United States and California, there was a big mail outreach program where a health system sent mailers to individuals with fibrosis scores of 3 or 4 to encourage them to get HCC screening. And then if they didn't answer the mailer, they had nurse navigators contact them. So this is a cumbersome project, but they did increase their screening rates from 30% to 50%, okay? So it can be done. A province in Australia had a similar study that showed improvements as well. In Germany, there was a major move to identify individuals with cirrhosis, and so they encouraged providers to look for platelet levels and to look for AST and ALT, and they identified cirrhosis at a higher level. This has not been validated to show an improvement in HCC detection, but it's a step in the right direction. The United States Veterans Administration, and there was also a national movement, similar concepts, both worked on provider education, reminders of the association, the importance of HCC screening, and then national movements. There have been a couple of success stories, both in Japan and in Thailand, where individuals have been encouraged to have screening done for viral hepatitis and to get screening for HCC. But you know, these are countries that put an entire initiative behind this because they feel like it's important. And they also have national health care where patients are not charged. They have easier access, and these tests are free of charge. So I don't know if it's really comparable to our healthcare system, but these are success stories. This is data that I looked at in our neighborhood in Baton Rouge. I work at FMOL, Franciscan Missionaries of Our Lady, and I wanted to see what our numbers were. So this was a slicer dicer. If y'all have Epic, y'all are familiar with a slicer dicer. And so in green here is the number of patients who had an encounter and a problemless diagnosis of cirrhosis. So in 2021, there were 3,700 patients. Of those 3,700 patients, there were only 273 that had ultrasounds. Now, it's possible that they had an ultrasound ordered by somebody else, but in our system, that's a pretty dismal rate, 7.3%. That's way less than that UT Southwestern study that showed a 20% rate. So that bothered me, and so with that information, I said, well, let's do a QI initiative. So what I wanted to do, and what we did, is we built a reminder and an automated order set into Epic to encourage providers to order screening ultrasounds on patients with cirrhosis. So it's an idea of using the EMR for good. I know it's been such a challenge for many people to navigate the EMR, but this may be something that would be a promising good thing that could come out of using the EMR. So first we went to radiology, and I said, look, if we order a bunch more ultrasounds on these 3,100 patients, can you absorb this? Will you be able to do it? And they said, yeah, we can do it. I said, okay, great. So then I went to the quality department for the health system, and I said, this is what I want to do. And they said, yeah, we like it. We'll support this. And so then they directed me to the Health Leaders Network. The Health Leaders Network is the group that's sort of responsible for the metrics that the primary care physicians are supposed to hit. And so I had to get buy-in from them because that's who we want to order the test. And so they supported it. So you can see this was quite a cumbersome list of folks. And then once we had approval from those, then I went to IT and said, can you build it? What would it look like? And they said, yeah, I think we can. And then they directed me to the Epic gurus. And so the Epic folks then did a build out. So, and during the process, this was something that was discussed with, the GI physicians, not only the primary care docs, but the GI physicians, obviously the radiologists, the cancer specialists in the system, in order to get buy-in from everybody. And so currently, this is what it looks like. And I know this is kind of small, but this is what, if you can see, if they have a problemless diagnosis of cirrhosis, then there's a reminder that pops up on the dashboard that says liver cancer screening is needed. And then you can see down here, you have the option to check this. This is an opt-in program. It's not mandatory. If the provider doesn't think it's appropriate, they don't need to select it. But it's just a reminder. It's a best practice advisory is what it's called in Epic, a BPA. And these are your options. So you come down here and you can choose AFP, you can choose ultrasound, and that's how we do it. So let me summarize. I got a few more things to speak, but I'm just going to stop and summarize for a second. HCC remains a major source of cancer mortality. The mortality rates are rising. It's the fastest cause of cancer mortality in the United States currently. The screening is not perfect. There are major problems with it, but it does reduce mortality. I think we've demonstrated that, and it is cost effective. Despite this, the screening rates remain low in the United States for multiple reasons. One major reason is we don't have USPSTF backing on it. But the future offers multiple possibilities for improvement. So I'm gonna close this out by talking about a few potential areas for growth and where we might see improvement in this. So there are some, I wrote GALAD, but this refers to some clinical risk scores that exist that are other than just AFP and ultrasound. So GALAD is one of many such clinical risk scores that incorporate additional biomarkers and sort of history, if you will, to better personalize someone's risk of HCC when they have cirrhosis. GALAD stands for gender, age, AFP, L3, and then DEP, which is another prothrombin biomarker. So that's one option. Another option is different radiological techniques. So abbreviated MRI is being considered, something called contrast-enhanced ultrasound, the possibility of using AI to improve radiomics, so radiologists could identify smaller lesions in the field of a cirrhotic liver is also being considered. So those are all areas of study. And then obviously the most exciting thing is the concept of a liquid biopsy, right? Many of the folks who represent liquid biopsies are in this room, so you all are quite familiar with this concept of taking a vial of blood and looking at nucleic acid and assessing the risk of malignancy based on the DNA or RNA profile within the vial of blood. But there are many ways that can be done, and I'll briefly run through that. This is a study that is actively enrolling patients. This is PI'd through UT Southwestern, and they are looking at the GALAD score, basically. And again, GALAD looks at gender, age, AFP, L3, AFP, and DCP, which is a prothrombin marker, and comparing the GALAD score to annual ultrasound and AFP, semi-annual AFP and ultrasound. And the primary endpoint would be reducing the proportion of late-stage HCC. They're attempting to enroll 5,000 patients. This is another study that's enrolling patients currently in the Veterans Administration. The goal is to accrue 5,000 veterans with early-stage compensated cirrhosis, and they're going to randomize them to have either AFP with abbreviated MRI, which is a quicker version of the MRI with fewer series, supposedly only takes 15 minutes, and comparing this group of patients to standard AFP ultrasound every 6 months. And the primary outcome would be HCC mortality. And then liquid biopsies, again, this is the way we assess nucleic acid within the bloodstream. There are many ways that this can be done: cell-free DNA, circulating tumor DNA, cancer cells, exosomes. And this table is very busy, but it basically talks about all of the strengths and the weaknesses and the potential clinical applications and the studies that have been done. To date, there are there's some promising tests that are emerging, but there's not one that is really head and shoulders above the other one. So it sort of remains to be seen. But this was a study that was, this probably holds the most promise in looking at circulating tumor DNA methylation. And I just point, this was a study out of China a few years ago, but the sensitivity over here, if you look at the sensitivity rates of AFP alone, 30%, ultrasound alone, 50 to 70%, AFP plus ultrasound, now you're talking about 80%, but when you add the circulating tumor DNA, it brings it up to 100%. So it may be that these modalities all exist together. We're not quite sure, but I think this offers potential promise for HCC screening as we move forward, because I think this is really going to be impactful for this group of individuals. So I think that's it. The future offers multiple possible areas for improvement. I would like to thank you for your attention, and I'm happy to answer any questions. I got Ms. Pam and then Dr. Sachs. Yes, ma'am.
So when did you implement your BPA screening for HCC at your have you seen that?
That's a good question. The answer is about a year and a half ago, about 18 months ago. And the results have not been, we moved the needle from a use of the BPA from like 1% to 2%. And the IT guys thought that was great. That wasn't really what I was hoping for. So I'm hoping for more buy-in. So it has not been used to the extent that I thought it would be used. So that's where we are. But it's a work in progress. Yes, sir.
So part of my practice is hematology.
Yeah.
And I get a lot of referrals for low platelets. And I am often the person that tells them they have cirrhosis. I usually order, as part of the workup for low platelets, an abdominal ultrasound. Do I need anything special looking at the liver, or?
No, it's a routine ultrasound. If you write liver screening, they ought to have a protocol to look for it, and you should add an AFP. That's a little bit debated, but like I was showing, the data indicates that it's more sensitive when you add the AFP to it. But I think that's it.
So the radiologists, ultrasonographers, hedge, like nodular,
Yeah.
Focal.
Yeah.
Steatosis or something.
Right.
They're trying to hedge and cover their ass on a scan.
Yeah.
And so once they see that, who am I sending them to? I mean, I'll get the AFP. Am I sending them back to GI? Am I sending them to you?
Well, I mean, yeah, I think the next step would be cross-sectional imaging.
So go to CT.
CT or MRI. Yeah, CT with and without contrast, liver protocol, saw something on the MRI, needs additional clarification. And then, it depends. If you've got a good GI doc who wants to embrace these, I think that'd be fine, alternatively.
And it's not really screening.
Yeah.
I mean, I'm seeing them for a different problem.
Right. That's right.
Some of them are at high risk and they're not being screened.
Well, if they're truly cirrhotic, then yeah, that would be, screening for liver cancer. But yeah, so you're screening them, even though they've got a different malignancy, you're screening them for something separate. But yeah, the algorithm goes, if you see something on the ultrasound, cross-sectional imaging is next. And whether you get an AFP, if you get a CT liver protocol or an MRI, you could split hairs there, but you want to get one of those. Yeah.
I think your patient's problem is they had an undiagnosed cirrhosis. So I think once the ultrasound picked that up, they should be referred to hepatology and such.
Hepatologists have few and far between.
Yeah, I was going to say, if you're in an institution with hepatology, then but right, on the North Shore, I know that they're few and far between, and on where I am in Baton Rouge, they're
Most things don't become senators.
So, any other questions? All right. Well, thank you.